Hey guys, can you see me? Hear me? Hello, hi, welcome. Good evening, Yukesh, Divangan, Sarkar, Krishna, Daksh. Hope I'm audible and visible. So say me hi. Okay, let's start. So today is about CVS and Lung. I think you must have definitely gone through a little bit of CVS and Lung. I have not purposefully included blood vessels here. We'll maybe deal a little bit of vasculitis, some other place. Vasculitis primarily is not there in your curriculum, but there is a very high chance you might get questions in vasculitis. Fine. Since CVS and lung, except for lung cancers, there are quite a bit of non-neoplastic conditions like inflammatory, infective conditions, right? We already learned a template yesterday for a neoplasm. We use the word risk factor, pathogenesis progression, clinical lab finding same, gross microscopy, right? Progression or types, and we added IHC here, right? So IHC heading and prognosis might not come for a non-neoplastic condition. It will be only for a neoplastic condition, fine? Hello, Suresh. Okay, so here for the non-neoplastic conditions, again, for every 5 mark or every essay question, 5 to 6 headings is more than enough to attract the examiner's things. That's all right. Etiology or risk factor. Again, this might differ. Not for every non-neoplastic condition, I have an etiology. Atherosclerosis, neoplastic or non-neoplastic? Good evening, Sinchana. It's definitely non-neoplastic. Atherosclerosis has etiology or risk factor. They have risk factor, right? So please use these terms accordingly. Tuberculosis, non-neoplastic, has etiology, right? Based on your question, based on whatever is the disease, the etiology and the risk factor, please use it appropriately. Pathogenesis will be there for every non-neoplastic condition. We'll have a quick look about them in few cases. Clinical history, lab findings, by default, it is must for every question, be it neoplastic, non-neoplastic. Gross, if it makes sense, do right. Microscopy, definitely. Again, progression and types also will hold true for non-neoplastic also for atherosclerosis. We do have progression of atherosclerosis from fatty streak to an atheroma. And your outcome, complication, aneurysms, could be an angina, could be an heart attack, right? All those are complications or outcome of any of the non-neoplastic condition, right? So this will be the template, basis template on how we are going to deal with few non-neoplastic conditions, right? Okay, first we'll go to atherosclerosis. Before going to that, can anyone tell me what will you fill in this for atherosclerosis? It's something you must have been reading from school days, right? We have the classical, modifiable, non-modifiable risk factors. That's how we're going to write for every atherosclerosis, right? What are the anyone? What are the non-modifiable risk factors? Non-modifiable risk factors: age, gender, any hereditary disorder are non-modified. Genetic modifications are non-modifiable, right? And modifiable risk factors: all the findings in metabolic syndrome, right? Your hyperlipidemia, hypercholesterolemia, smoking, alcohol, your hypertension, diabetes, everything will come under the modifiable risk factor, right? Your age, everything is non-modifiable. Rest everything comes in the modifiable risk factor. Fine. Again, for a non-neoplastic condition, start with the definition if possible, a single line. For a cancer, you need not define it. Cancer is a cancer. Everyone knows that, right? It's a progressive primary disease of tunica intima involving large and medium sized muscular and elastic artery. Atherosclerosis is very, very unlikely in a small sized artery. So every word here is important. It's a disease of intima. It's not actually disease of the entire vessel. It's an intimal damage and the entire plaque happens in the intima and of large and medium size. That's what we call it, atherosclerosis, right? We have for small arteries also a thickening. We call them arteriolosclerosis, fine? Okay. We have them for arteriosclerosis, right? So which disease you will have arteriosclerosis? You will have it for your hypertension, right? Your hyaline or an hyperplastic arteriosclerosis, right? So these are the modifiable, non-modifiable risk factors. If you know, if you want to explain this in extra, you can write the type of hypercholesterolemias, whatever you know, right? Hyperhomocystinemia, I have written in both. Hyperhomocystinemia, if it's genetic, the cystathionine beta synthase defect, okay, the enzyme defect, then it is going to be a non-modifiable thing. Hyperhomocystinemia can also be due to vitamin deficiency. B6, B12 deficiencies can also result in hyperhomocystinemia. That will be under the modifiable risk factor, right? These are risk factors, that's all. Again, we need to have a pathogenic model and a progression. Atherosclerosis, can I call it a chronic inflammation? Will that be right to call an atherosclerosis a chronic inflammation? It is undoubtedly chronic inflammation, right? So by default, there is a beautiful diagram in Robbins. Whatever book you follow, the same diagram will be given, right? If it's possible, draw this diagram. It's not difficult to draw this diagram. You need not have this much amounts of beautiful things, right? Simple line diagram is enough. An endothelium, a tunica media, and your tunica, right? Intima, media, and your adventitia. Fine. Okay. So the 3 layers, that's all. Fine. So what happens is whenever there is a risk factor, be it hypertension or be it diabetes or be it hypercholesterolemia, all of them might cause a very tiny microvascular injury. So whenever there's a tiny microvascular injury, by default, the cholesterol, the fat might enter into the tunica intima or the endothelium, right? There'll be entry of fat into endothelium. The fat into endothelium is the first insult, which is going to cause endothelial damage by default. But here is where we have to little bit learn more about the pathogenesis. It's just not a chronic inflammation. Little bit deviation will give you more marks. That's all. Whenever fat enters into the cytoplasm of every cell, it will trigger your inflammasome complex. Please don't forget this. I'll tell you why. Inflammasome complex will be triggered, be it your cholesterol crystals, be it your uric acid crystals, anything in the cytoplasm. This is trigger, right? This is important because it's a new concept. Previously, we didn't have the idea of inflammasome thing. We just thought that, okay, fat is there, macrophage comes and eats it. That's what we thought. But inflammasome is a very important thing because modifications treatment, we can easily modify inflammasome complex, right? Yes, exactly, sir. Pyroptosis. After inflammasome, you'll have the interleukin beta 1 converting enzyme. You'll have definitely increase in interleukin 1. That's one of them. Obviously, it will also have cell death, which will be caspase activation as well, right? Both of them will happen by default. This interleukin 1 is going to attract more and more WBCs. So here my WBC, since the chronic process, obviously macrophages, right? This attraction of the WBC, here you can see clearly the monocytes will enter the place. So it's going to eat the fat particles, which is being deposited in the subendothelial space. You can see the fat particles here deposited, and also fat particles will be there inside the endothelium as well, right? It will be attracted, and this attracted WBC, especially the monocyte macrophage system, that's what is going to attract. So the monocyte macrophage system enters into the subendothelial tissue and will attract them. So the first stage here also, it's pathogenesis and progression. Please, for a long answer or a short answer, don't differentiate them, right in the same place, because ultimately more information you give in a flowchart, it's much easier for the examiner to correct, right? Now here you'll have the fatty streak. So fatty streak is the first and the initial finding seen in atherosclerosis, where you have foam cells, which are nothing but your macrophages in the tunica intima, but no fibrosis. There'll be no fibrosis, there'll be no necrosis, there'll be no wound healing, just foam cells trying to engulf whatever foreign fat has been deposited there. That's the first thing, right? Going forward, more and more subsequent damage, or when you have repeated injuries, automatically it's going to cause chronic inflammation, which is tissue destruction, healing by fibrosis, right? So ultimately what will happen in an atherosclerotic block is you will have in the center, you'll have necrosis plus fat. The surrounding, you'll have little bit of your inflammatory parenchyma, your macrophages, and above that, it's a healing tissue, right? It's a chronic inflammation healing tissue. Above that, you'll have the healing scar tissue. If it's possible, draw like an elongated spindle shaped structure. Just mentioning, it's a fibrous cap, right? So you have a fibrous cap, you have a central necrotic core, and surrounded by macrophages here and there. This is what causes atheroma, right? This gives us all the information required in one page. That's more than enough, right? Again, just quick go through. Any of the risk factor can cause a tiny damage. The fat enters the endothelium, gets deposited subendothelial tissue, triggers pyroptosis, inflammation, interleukin comes, attracts more and more WBC. The WBC eats everything, but with repeated injury, tissue destruction and healing by fibrosis is going to happen. That's what primarily is atheroma, right? So now let's look at gross. Gross, again, I have two things here. One, it is fatty streak, just a simple normal thing. Other is atheroma, or a well-formed atherosclerosis. Whenever you write in gross, again same thing, fatty streak and atheroma. Fatty streak, will it be flushed with the surface or will it be elevated? What do you think fatty streak will be? It's a very initial surface, right? It will be flushed with the surface of the vessel. It will not be very high because there's no destruction, there's no fibrosis, right? So it's flushed with the surface, and obviously it'll be yellowish in color. Okay. Atheroma on the other hand, you can draw a diagram for an atheroma, draw a blood vessel, cut surface of a blood vessel, right? Atheroma on the other hand will definitely be a little bit elevated. So this is how atheroma will look. It might be ulcerated or it might be a plaque. Plaque is an irregular elevation on any surface. That's what we call it, a plaque, which can or may not narrow the blood vessel lumen, which can narrow the lumen of the blood vessel. That's the well-formed atheroma. What happens? This atheroma by default can flow. Flushed with the surface means that you have a mole, right? Mole that is flushed with the surface. If you touch it, you won't see an elevation, right? You have a pimple, you have an elevation. That's not flushed with the surface, right? Flushed with the surface means it's flat. That's what I mean by flushed with the surface, right? Or right flat, that is also more than enough, right? Now microscopy. Again, microscopy, use these terms. We already know the microscopy of your fatty streak. I'm not going to emphasize here. My main goal is the microscopy of atheroma, right? Microscopy, this is an image from Robbins. If possible, draw the image. If not, just draw a descriptive diagram. Same way what we drew, right? We have a necrotic center. Necrotic center will obviously be in pink color for necrosis. If you have colors, again draw for yellow color fat cells. And obviously you have the smooth muscle and everything coming inside, right? Or the myofibroblastic tissue coming inside. You can draw them in elongated structure, right? Okay. The most important thing in a diagram, see, diagram should be representative. If you draw a diagram, it has to be representative. In the initial introduction or the definition, I said atherosclerosis is a damage to blood vessel or a damage to intima. What do you think is atherosclerosis? Blood vessel damage or an intimal damage? It's undoubtedly an intimal damage, right? Which means the most important thing for me is this layer. Can anyone tell me what this layer is? This is the most important thing here, right? The lowermost layer is internal elastic lamina, right? IEL. So everything in an atherosclerosis happens above the internal elastic lamina, which means it's intima, right? The location is very, very important. So if you want to mark a fibrous cap, which is made of fibrous tissue and myofibroblast. You can want to expand, right? Fibroblast and myofibroblast, right? And the necrotic core here, composed of necrotic cells and your foam cells and everything, right? Okay, Nikita, we need to draw adipocytes, right? These are fat deposition. These are not fat cells, right? Cholesterol is different from an adipocyte. Draw a clear empty color, that's more than enough. Or you can draw an yellow color representation to say it's filled with fat. That's all, fine. This is an image from Robbins. Just let's test our knowledge. What stain do you think this is? Anyone? At least nearby, not the exact stain I want, anything near in the vicinity that should hold true. That should be more than enough for us. Any guesses? What stain is this? You are seeing a fibrous cap which is blue in color. Collagen, blue color. What stain is that? Perfect. That's your trichrome, right? That's a Mason's trichrome. It's a stain of Mason's trichrome. If you want, you can add that in a Mason's trichrome stain. You can definitely very well appreciate the fibrous cap, right? That's a possibility. You can write it, right? Again, it's all based on your nature, on how big you want to write or how crisp you want to write. That's all. We can extend the question to any extent you want. You can cut it short to any extent you want, right? So we know the gross, we know the microscopy. By default, outcome is required. Can anyone tell me what could be the outcome of atherosclerosis? What all could be the outcome of atherosclerosis? Yes, Meet, you're right. Any outcome what comes to your mind? Outcome, again, you can elaborate it based on the mark. If it's atherosclerosis, generally comes in a long answer. If the outcome is given for 5-6 marks, elaborate it. If the outcome is for only 1-2 marks, don't elaborate it, right? Atherosclerosis rupturing is not the primary outcome, right? Atherosclerosis occlusion is a primary outcome, right? Atherosclerosis can cause atherosclerotic stenosis, which means there is a possibility there can be increase in the atheroma or the atherosclerotic plaque. Both means one and the same, which can slowly narrow the vessel lumen. Okay, when it narrows the vessel lumen, and it can cause ischemia. Perfect. Ischemia is definitely possible. Example, you can write angina. Angina is obviously an ischemia, right? There is a possibility this can undergo critical stenosis. these words are important. When I say critical stenosis, more than 90% of the lumen is narrowed by the atherosclerosis. We call it critical stenosis. Critical stenosis causes infarct. It's not ischemia, it's infarct. Example, MI, right? So this is the first outcome, right? It won't rupture exactly. I can have an ulceration, erosion, or rupture, which is not very common, right? Which is secondary. Stenosis is definitely more common. This, if you remember, any of the plaque change, you can also write this as secondary plaque changes. Plaque change, any of them, will cause a superadded thrombus. We know that, we have read that already. I'll have a thrombus on top of that because the topmost layer by default is intima, right, or the endothelium. Okay, the superadded thrombus can definitely cause an infarct or can occlude the entire vessel completely. So this will cause a sudden infarct or a very slow gradual infarct. Superadded thrombus, sudden. So this is a perfect example of an unstable angina, right? Again, like I said, based on how much mark they are asking the outcome is, based on that, expand it. If they're asking for 5 marks, write at least 3-4 lines for rupture alone. Draw a diagram, how a superimposed thrombus comes, why it's called as an unstable, it's a sudden change. There's a possibility the atherosclerosis, which is very, very unstable, can break and go anywhere. Just give me a second. Skip. Is it fine? I hope it should be good. Fine. Okay, let's come back. Atheroembolism, right? So when I say atheroembolism, this atheroma, I think it's good, can break, can enter into the blood circulation, and they can block renal vessels. That's a very common place where embolism can happen. It's like any other embolism, this embolism can also happen, right? There's a slight bit of lag. I think it should be normal within a couple of seconds. Fine. Okay. Clear? Okay, that's atheroembolism, right? Last but not least, aneurysm formation, right? So by default, atherosclerosis can weaken the wall of the vessel. If it can weaken the wall of the vessel, by default, it can cause dilatation, which can cause aneurysm. Okay. Again, like I said, if the examiner is asking the outcome for 5 marks, explain aneurysm. You know the true aneurysm, you know the false aneurysm, you know the different types of aneurysm, right? All of them can be easily explained, right? Not just that, it can also lead to aortic dissection, right? So I am having a very weak blood vessel wall with a coexisting hypertension in the same patient, it can dissect and also go out, right? So all these are different possibilities of an atherosclerosis, different outcomes of an atherosclerosis. I want you to write the exam based on what the weightage of marks is, right? So this simple thing about atherosclerosis, everything non-neoplastic have a template. Non-neoplastic should start with a one-line definition of your term. Again, etiology or risk factor based on the question. Pathogenesis progression based on the question, right? But remember, every non-neoplastic is either acute inflammation, chronic inflammation, autoimmunity. Create one template for everything. Pitch in perfect in whichever organ it is, change it accordingly, slightly. That should be more than enough, right? Gross based on whatever is required. Microscopy, diagrammatic description is always better than writing a theoretical points. Write theoretical point also. Okay, outcome is based on atherosclerosis has 5 different outcomes. It can definitely cause Devangan, since the abdominal aorta is one of the commonest site of atherosclerosis, and there is a very narrow fragment of renal artery going exactly from aorta to very tiny, right? So the chance of them going and blocking the renal vessels is a bit higher than chance of going them and blocking the CNS. But it's just like any embolism, it can affect anywhere in the body. It can be a peripheral arterial disease or it can be a brain. It's embolism, that's all. This is more common. Fine. Okay, got it. This is about atherosclerosis. Fine. Let's come to rheumatic heart disease. Okay, again, rheumatic heart disease is a non-neoplastic condition. We need a slight bit of definition, right? Rheumatic fever is an acute post-streptococcal immune-mediated multi-system inflammatory disease. It's not a disease of the heart, right? So whenever you write rheumatic heart disease, Pranam Dalit, we have two major things. We have an acute rheumatic fever and a chronic rheumatic heart disease. See the question what they are asking about. Is it about rheumatic fever or a rheumatic heart disease? Based on that, you can pitch your answers. But if you're not able to differentiate just rheumatic heart disease, write both. Anyway, it will be acute, only then it will become chronic, right? So write both. But I have different things. One is acute rheumatic fever and other one is chronic rheumatic heart disease. Stenosis will not come in acute. Regurgitation is more common in acute, and chronic definitely. Fibrosis and stenosis is very, very common, right? Good evening, comrade. Fine. So now pathogenesis. You guys are going to tell me what will be the pathogenesis. Rheumatic fever is one. You must have read in medicine, you must have read in pediatrics, you must have read in microbiology, you must have read in pathology, right? In spite of that, if you make a mistake, no one can help you, right? Rheumatic fever, we have a very set template of pathogenesis. You should never ever forget that, right? So which streptococci? Alpha hemolytic, beta hemolytic, group A, group B, right? It's your group A, beta hemolytic streptococci, right? So I'm sure by this time you must be thorough about this, right? Post-streptococcal infections, right? Sinchana, but it's little bit more effort, right? Group A beta hemolytic streptococci, which is having a molecular mimicry. It's need not be a knowledge from your microbiology. It need not be knowledge from pathology, wherever it is, right? Group A beta hemolytic streptococci having a molecular mimicry of its M proteins with human antigens, right? So with human antigens, I'm writing human antigen because it can cross react with my heart, with your skin, with your joints, with your blood vessels, anywhere, right? With cross reaction with human antigen, so you have a bystander effect. So bystander effect here is very simple, where my body destroys my M protein, definitely my body also will destroy all the human antigen, fine? That's how it is. It's a very simple pathogenesis, and I'm sure you know, you can easily write it, right? Now let's come to criteria. Major criteria, minor criteria. Here, I'm not going with terms of clinical features because here criteria is more important than anything, right? So major criteria, you have A, C, C, E, S. This is what was being told when I was in UG, but I'm thinking you have many more mnemonics here now. I'm sure you will never forget that major criteria, right? If Jones, we can't forget Jones, right? Sir Duckett Jones criteria, right? So you have arthritis, right? Migratory polyarthritis of major joints. It's just to remember, right? It should be migratory, it should be polyarthritis, multiple joints, and it should be major joints. All these are very, very important to diagnose rheumatic heart disease, right? Carditis, again, you know that it is pancarditis. It's your endocarditis, it's your myocarditis, as well as your pericarditis. If it's a long answer, explain each of them. If it's a short answer, just write a word. That's enough. Chorea, Sydenham's chorea. Okay, Sydenham's chorea is generally a very late or a delayed feature. Write that because that's a very important thing which every examiner wants to know. Erythema marginatum, and you have subcutaneous nodules. Self-explanatory. Erythema, which is a bit of a circular lesions in the skin, and tiny nodules on the extensor aspect, subcutaneous nodules. Minor criteria, arthralgia, fever. I have just written elevated inflammatory markers, which includes ESR, CRP, neutrophils, and everything. All of them are inflammatory markers by default, right? These are minor criteria. When you have this, I can easily suspect a rheumatic heart disease or acute rheumatic fever. Fine. Some supplementary lab findings of your DNASB, ASO titer, you can add them also. Fine, along with the criteria. Then gross. Gross again divide into acute and chronic, because for acute there's a different gross feature, chronic there's a different gross feature. Fine. So acute rheumatic fever. Let's go to chronic because I'm sure everyone knows about chronic first, right? Can anyone tell me what gross feature comes to your mind when you think of a chronic rheumatic heart disease? Anything? Chronic, someone already said, I think Sarkar said it long back, it's the fish mouth appearance which comes to your mind, right? Chronic means by default it is fibrosis. Every chronic rheumatic heart disease or every chronic inflammation will have fibrosis, right? So by default, a chronic rheumatic heart disease, the predominant finding is fibrosis. So fibrosis, it can result in a bicuspid valve. It can result in a fish mouth appearance. If you want, you can draw it, right? This is how a bicuspid valve looks like. And when it's fibrotic bicuspid valve, it kind of looks like a fish mouth. It's just a fibrotic valve, that's all, right? A tricuspid valve also will have stenosis. Definitely there'll be stenosis. You cannot avoid that, right? And most of the fibrosis will result in commissural fusion. The commissures of your valves will fuse. That's the reason you're going to end up in stenosis of the valve. Fine. Okay. That's what happens in chronic rheumatic heart disease. When you come to acute, can anyone tell me any finding in acute? Perfect banana shake. Put your name. No, your name is much better than banana shake. Acute. One finding in acute which you should not forget is vegetations, right? Vegetations by default is a very, very classical finding of rheumatic fever. Vegetations are nothing but irregular deposits on the valve surface. They are very tiny irregular deposits of the antigen, antibody, or the immune complex on the valve's surface. What is the name of vegetation in rheumatic heart disease? We call them a verrucae. Again, if it's a long answer, explain that. Explain that a little bit more. Fine. Verrucae. Okay. Now let's ask questions related to medicine. Nah, that's not required. We'll chat private. Okay. So that's about vegetations, right? So when you, again, someone said about McCallum's patch, right? McCallum's patch is a very, very important finding which can be seen due to mitral regurgitation and the break of the, or the rupture of the your chorda tendineae and everything, right? So because of the mitral regurgitation, the regurgitant jet of flow, okay, can hit the left atrial wall, and the left atrial wall will have an irregular area. Okay. Sinchna, it's a good finding, Ashoff nodule. Can you see an Ashoff nodule in gross, or it's more of a microscopic finding? Ashoff is more of a microscopic finding, right? Gross, it's a bit difficult to identify an Ashoff body. Microscopy, definitely you can easily pick up an Ashoff body, Anichkov cells and everything, right? Again, you can write the bread and butter pericarditis or bread and butter pancarditis. That's also seen on an acute finding than in a chronic finding. It's nothing, instead of writing bread and butter, if you want to write fibrinous pericarditis, that also is more than enough. That's what actually bread and butter, right? The fibrinous strand appears like a bread, a butter thing. That's what we call it, bread and butter pericarditis. Fine. Okay, this is for acute and chronic. Same way, when you go for microscopy, acute, only one finding which is important in your rheumatic heart disease, Ashoff bodies. Chronic, it's fibrosis. Ashoff body can also be seen in chronic, but it's a little bit less evident than in acute, right? In mostly it's seen in acute rheumatic fever than in a chronic rheumatic heart disease, because chronicity is more predominantly by fibrosis than an Ashoff body or an acute damage, right? Good evening, staff. Okay. Again, if it is an essay question, you can give the different things. There is a early change, there's a late change in Ashoff bodies, but if it's just a single finding, just write Ashoff body is nothing but, what are they? They are a collection of T cells, macrophages. What are the macrophages called as? We call them Anichkov cells, right? If you love the caterpillar chromatin, write the caterpillar chromatin. You can have many mononuclear cells, including plasma cells, and most importantly, surrounding fibrinoid necrosis, right? So you have this fibrinoid necrosis. This collection is pathognomonic of rheumatic heart disease. Okay, it's a very classical finding. Pathognomonic means I should have this. If it's there, it's only rheumatic heart disease, right? It's pathognomonic of rheumatic heart disease or a rheumatic fever, though it's more commonly seen in acute rheumatic fever compared to chronic rheumatic heart disease. Even a McCallum's clock in microscopy, you will see an Ashoff bodies. Ashoff body can be seen anywhere, but it's most commonly seen in case of a junction of your myocardium and the endocardium, right? Mitral insufficiency is nothing but, champion, it is a damage, right? It's a damage to the, let's assume you have a, your chorda tendineae, it's ruptured, broken, you'll have insufficiency, fine? Good question, Vamish. If mitral insufficiency has, see, can I say that almost everyone here must have had rheumatic heart disease? Sorry, must have had streptococci? Yes, right? Not everyone goes into rheumatic heart disease, right? So molecular mimicry is there, right? Sometimes, most of the times, for most of the kids who get a streptococcal sore throat, it will be taken care. It will be properly taken care. Unless and until there is a defect in the immune system, it will not go here, fine? Great stuff. Okay. That's why it's more common in few sectors. It's not seen in everyone. I hope it's clear, Ramesh. Fine. Okay. Let's go to the next one. Occupational lung disease. Fine. Occupational lung disease. It's again a short answer one. That's okay. Okay. Fine. So occupational lung disease. There's a template pathogenesis for every occupational lung disease, be it a silicosis, be it a coal-workers pneumoconiosis, be it your asbestosis, or be it any occupational lung disease, right? For every occupational lung disease, when you have any of that, be it a coal, be it a silica, be it anything, right? Anything, once it is inhaled, it'll go into the lung parenchyma. Macrophages will swallow them. Macrophages will present them to the T cells. When macrophage presents to the T cells will be stimulated to the Th1 pathway. It will automatically result in a granuloma formation, right? It will definitely result in a granuloma formation, and all of these granulomas will be non-necrotizing or non-caseating granulomas. That's how it is, fine. But the stimulus here is not once in a while. It's not like TB. You got a TB organism today, that's all. No, it's again and again and again till the person works in the occupation. This inhalation will be repeated. Again, you'll have one more inhalation, one more stimulus. Since the stimulus is persistent, anywhere you have persistent stimuli, it becomes more and more and more and more inflamed, more and more active, and definitely it will end in fibrosis. That's why most of the pneumoconiosis are fibrosing lung disorder. They are not granulomatous lung disorder. They are all fibrosing lung disorder. Fine. This is the template for every pneumoconiosis. Change this based on what the question is asked. Right. So I have a template pathogenesis. You can write it for any pneumoconiosis. Ultimately, I have granuloma, which will end up in fibros. Right. So what you need to write in pneumoconiosis, very few points. One, occupation. I need to have the occupation that I am sure you know. Second is pathogenesis. Right. This is a template for everything. Third, if you have any different types of the coal, of the silica, of the asbestos, I'm sure you know. Fourth, is there any unique presentation? Silica involves a very classical hilar lymph node. What is that? Can anyone tell that? Hilar lymph node silica is a very classical presentation. That is your axial calcification, right? Perfect. So I can have the axial calcification. That's only for silica, right? Asbestos, we have the ferruginous body. That's my microscopic finding. Asbestos can cause cancer. Silica can cause cancer. Coal cannot cause cancer, right? So few template, before writing any question, think for a minute. You will definitely know more than what to write, right? So I know the template pathogenesis, then we go for the coal workers pneumoconiosis, right? In the coal workers pneumoconiosis, we have work. It's coal mining. Obviously, that's the work here. Particle, I have anthracite coal. There's one more type of coal. If you want, you can add it. Bituminous coal. Bituminous coal is not seen in coal workers pneumoconiosis. It comes from firewood cooking. Okay, it comes from a firewood cooking. That's why the bituminous coal, that is unrelated to coal workers pneumoconiosis. In coal workers, I have anthracite coals. That's all, fine. In coal workers pneumoconiosis, we have three different diseases. We have your anthracosis, though it's not a disease, that's a starting point where every one of us will have. Then I have simple coal workers pneumoconiosis, simple CWP, and then we have complicated CWP, complicated coal workers pneumoconiosis. Fine. Good evening, Sam. So again, for this, I need a very tiny gross finding, microscopic finding, lung function. This is the same table what you must have read in the routine classes as well, right? It's very simple. Anthracosis, it will not have any classical gross finding, just few black deposits. Black deposits on the lung surface, which can be seen in your lung, my lung. Every person living in urban cities will have it. Not urban, most of the rural cities also will have it, right? Okay, microscopy, you'll have pigmented macrophages. Okay, you'll have pigmented macrophages in the microscopy. That what will be there. You will have no granulomas here in case of an anthracosis. Lung function will absolutely be normal, fine. Simple coal workers pneumoconiosis, 0.1 to 1 centimeter nodule. There's no fibrosis here, but you'll have definitely non-necrotizing granuloma. So lung function will be altered. It's granuloma, reversible or irreversible? Anyone? Reversible or irreversible? It is definitely reversible. Okay, it's undoubtedly reversible because granuloma formation is definitely reversible. So lung function also will be reversible. Fine. Okay, complicated Kohlberger's pneumoconiosis, 1 to 10 centimeter lesions. It can be throughout the lung also. The most important thing here is fibrosis. Fibrosis is more important. Whenever it becomes fibrotic, obviously it is. It will also have an altered lung function, but it's irreversible. Okay. Always end with a complication. What do you think will be the complication of Kohlberger's pneumoconiosis? Cancer or respiratory failure? What do you guys think? Cancer or respiratory failure? Complication of Kohlberger's pneumoconiosis? Undoubtedly respiratory failure, right? So complication in case of CVP, you might end up in having a respiratory failure. Kohlberger's pneumoconiosis will not result in a cancers. There is no increased risk of carcinoma formation. You can write that. Only silicosis and your asbestosis and quite a few other occupational lung diseases can have increased risk of carcinoma. Your anthracosis does not, or Kohlberger's pneumoconiosis does not have a increased risk of carcinoma. Perfect, right? Next, silicosis. Same template. Somewhere here, I want you to put the word pathogenesis. We already know the pathogenic model in the template. Include that. That's all. Fine. Silicosis, sandblasters, stone cutting, polishing the marbles and everything. Glass ceramic manufacturing. You have silica particles. They can have silicosis. Right. Two types of silica. Same like coal and asbestos. Crystalline and amorphous. Amorphous not very important. Crystalline quartz. As a type of silica you must have seen in watches. That's the most toxic or the most fibrogenic silica. Fine. Gross, you can have a mostly in the upper lobes of the lung. You can have a well-defined nodule. They might sometime mimic cancers. They are very well-defined nodule like a tumor. That's a classical finding of silicosis, right? And also, though it's not gross, radiology, in your hilar node, you might see an eggshell calcification. Peripheral calcification hilar node, that's what is an eggshell calcification. Write that. Mostly seen on the chest x-ray. It's a chest x-ray related finding. That also is gross. It's to naked eye, not in microscopy, right? Microscopy, same. I'm going to end up in having a fibrosis. In early stages, obviously you'll have non-necrotizing granuloma. How do I differentiate or how do I know if a microscopy is alone given? It's a silica particle or a carbon particle. Carbon particle will have a color, right? With a black color, I can easily say it's a carbon particle. How can I identify silica? We have read this in the classes. Anyone, anyway, to identify the silica? Perfect. It's a polarized microscopy. Fine. A polarized light on a polarizing microscopy, silica is positively birefringent. It's extremely birefringent because like any other sand particle, silica can reflect light. That can be seen here as well, right? It's a positively birefringent particle seen in the light, right? Perfect. Risk, again, add two things. One, definitely respiratory failure is undoubtedly an important problem here. The patient can end up in a respiratory failure due to interstitial fibrosis and interstitial lung disease. Is there a risk of cancer formation here? Sure, Sadaf, send it across. Hi, have fun. Yes, this can definitely increase the risk of carcinoma. Silicosis can increase the risk of carcinoma. Your asbestosis can increase the risk of carcinoma. Kohlberger's pneumoconiosis alone does not have an increased risk of carcinoma. Fine, perfect. That's about your silicosis, right? Then let's go to asbestosis. Just one thing. I'm just summing up all the important things that has to be in your paper. If these words are there in the paper and a tiny representative diagram, it's more than enough. They'll give you easily 3 on 5, right? Basic is 3 on 5. Based on what you can explain, you can easily get more than that as well. Fine, perfect. Okay, Kaplan syndrome also, if you want, you can write it. Fine. Asbestosis. Asbestosis. No, Sumit, you have many more important things to see. Watch that. Come back to MBBS. We'll learn this. Insulation industry, cement shipwreckyards. When they break ship manufacturing, all the places where you use asbestos particles, yes, this can increase the risk of asbestos, right? Particles, two types, serpentine and amphibole. Serpentine, it's serpentine, right? It's like a snake. It's a malleable particle. It's most commonly used. Less pathogenic or more pathogenic? Amphibole are sharp fibers, rarely used. Less pathogenic or more pathogenic? This is Perfect. Less pathogenic. It's good for us. It's less pathogenic because they can easily escape the lung parenchyma, right? These are more pathogenic fibers and they are rarely used. Again, that is very, very good for us, right? Okay, we have two types of fibers in asbestos, serpentine and amphibole. Fine. So once you know that, again, the same pathogenic model, right? Whatever it is, you inhale, the macrophage ate, macrophage could not destroy, presented to the T cells form granuloma, repeated exposure result in fibrosis. That's the same pathogenesis for every pneumoconiosis. Fine. Then come to the clinical features. I'm just talking about three main findings. The first is pleural plaque. It's the most common finding. Most of the time, this is an incidental diagnosis because we do have occupational occupation related programs. Health screening tests will be done for every person working in a factory, right? During the Employment Act and everything. There we can, when you take an X-ray, you might find them incidentally, right? These are seen on the lateral aspect or the basal aspect of the pleura. That's where it can commonly seen. Okay, it's nothing but just a thick pleura. Grossly, it's a thick pleura. Microscopy, you can have a little bit of calcification. That's all. It's a thick pleura. It's not a cancer. It's not symptomatic. They are completely asymptomatic. That's why they are incidental finding. But these people should be definitely kept on follow-up. Fine. It can result in pleural effusion. If you want, write the histories or presentation of pleural effusion. It can also result in your interstitial lung disease. Nihal, don't worry, it's fine. It'll be overwhelming, but once you complete it, you'll feel that it's easy, right? Consolidate whatever you've read, just revise one more, talk to your friend, do a group study, you'll definitely do well. Fine. Interstitial lung disease might result in a respiratory failure. That will be the outcome here as well. It can also cause carcinoma, right? There's a most repeated question for you. Which is most common? Which is most specific? The most common carcinoma it can cause lung adenocarcinomas. The most specific carcinoma it can cause is mesothelioma. It can also cause tumors outside the lung, extrapulmonary. It can cause peritoneal tumors. It can cause ovarian tumors, right? Most of the intraperitoneal organ tumors, it can definitely increase the risk of them. Ovarian or in peritoneal, which is peritoneum also can have mesotheliomas, peritoneal carcinomas, all those things. This can increase the risk, right? That's about asbestosis. And not last but not the least, how do we find microscopy of asbestosis? We have ferruginous bodies. Okay, we have ferruginous bodies. That's a classical finding seen in asbestosis. Draw a diagram if possible. Put a square or a circle, whichever is comfortable for you. It's iron ladder, right? So draw a brown color thing. Maybe it is inside a macrophage, a brown color, irregular structure called a ferruginous body. And this ferruginous body is nothing but iron plus the asbestos fiber. Asbestos fiber is generally very transparent, right? It's a very thin fiber, right? You have iron coating the asbestos fiber. That's how the ferruginous body is formed. And obviously it's pulse positive because it's made of iron. Fine. Omkar, I'm not the right person to talk about zoology. You have amazing teachers in PW or any other platform. Please go and have a look at them. Okay. Then it can, right? Asbestos can also go, carbon can also go, everything can go into the hilar lymph node. But the chance of your axial calcification is seen more in your silicosis because silica is more damaging compared to rest of everything. Okay, that's why it is more damage, more a chance of having hilar lymph node calcifications. Fine. Okay, let's go to lung cancer. Lung cancer is a very, very potential lung cancer. There's a very high possibility lung cancer can come in a lung cancer, especially in paper 2. Fine. For every cancer, same template. Risk factor, pathogenesis, progression. If it's possible to write like cervical cancer from normal CAN 1, 2, 3 cancer. Like that, if you can form a grade, that will be great. Otherwise, just whatever you know about the pathogenesis, right? Gross microscopy. In microscopy, talk about subtypes. Lung has multiple subtypes: squamous, adeno, neuroendocrine. All of them. Few words about the microscopy and IHCs must, if possible, a word about the treatment. Same surgical, chemotherapy, radiotherapy. No one is going to ask you why you wrote this, or it's not wrong in writing that, but it should always end with management, right? Any risk factor for lung cancer? What's the risk factor for lung cancer? I'm sure you guys know that. Smoking is undoubtedly the most common risk factor. right? Pure tobacco smoking, a chronic smoker, and by default, the person is going to have a risk of lung cancer, right? Smoking, pollution, you cannot avoid that. Definitely it is there. Radiation exposure, maybe due to something else. You have a radiation in the mediastinal area, it can definitely affect the lung, right? Tahir, microscopy, it might be good if you draw a representative diagram, easy diagrams. I'll tell you how to draw. Just simple diagram should be enough. Fine. Okay. Undoubtedly chronic smoking. Smokers means chronic Tahir. That's why I always ignore that. Chronic continuous smokers will have an increase in risk of lung cancer. Idiopathic or an interstitial fibrosis can have, and not every few occupational lung disease can have it, right? Namaste Pratik. And genetic mutations. In mutations, I want you to name the mutation KRAS, right? That's important. EGFR and ALK, primarily for lung adenocarcinoma. At least in this place, my mutations are very important compared to your squamous and your neuroendocrine tumors. That's not much important. Though I have classical mutations seen in small cell carcinomas and neuroendocrine like P53 and everything. ERBB1, perfect, right? You can write that as well instead of EGFR, fine. Okay. Genetic mutations for squamous, if you want, right, but it's not important. For small cell, again, if you want, right, but it's not important, right? P53 can be seen in small cell carcinomas of lung. Retinoblastomas are mutated in squamous cell carcinomas of lung. This is not must because it's not diagnostic. Other three mutations are diagnostic, fine. Yes, so Sarkar, it is in the pathogenesis, but for any cancer, keep it a routine to write sporadic risk factors, genetic risk factors. That's all. That's the reason I put it here. Genetically, I can have the mutation because it's a template, right? Let's fill in the template. We can definitely use them in the pathogenesis also. Fine. Okay. Let's go to the pathogenesis risk progression. We'll go one for your small cell, one for your adenocarcinoma. Neuroendocrine tumors has almost the same pathogenesis of small cell carcinoma. It's smoking related most of the time, right? So here, when you have any crude variant of smoke with a bigger particle size, that's what primarily it will settle in the bronchus. When it settles in the bronchus, it's a carcinogen by default, right? So once it settles in the bronchus, it will cause, first thing is squamous metaplasia. By default, it is reversible. If the person stops smoking, it will come back to normal. If the person still persists smoking, so only continuous chain chronic smoker will end up in having this, right? It will undoubtedly go to dysplasia. Dysplasia also low grade is reversible. Fine. Then we'll go to, just a way for you to have a 30 classes, 24 or 25 classes, just a final rush. If you have any doubts, do let me know. If you have any topics, if you want, do let me know. We'll cover them as well. It's not possible for us to cover everything in the last 10 days, but the common things which is required and a template so that we can answer the uncovered topics as well. That's all, fine. Okay, that's a template for a simple squamous cell carcinoma. If you want here, you can add the retinoblastoma, P53, TERT, all the mutations required. Though it's not required, if you want, you can add it, right? That's for your squamous cell carcinoma. The same template you can write for a neuroendocrine tumor. The only change if it's a neuroendocrine tumor is, again, smoke is the reason. Smoke converts a neuroendocrine cell or the Clara cell, which is the neuroendocrine cell of the lung, to something called a tumorlet. Tumorlet is like your dysplasia of squamous cell carcinoma. From tumorlet, it becomes carcinoid, or it can become atypical carcinoid, or it can become your small cell carcinoma. Fine. Those are the grades of the tumor with more and more mutation. The final hit is P53. When P53 is gone, it becomes the most high grade squamous cell carcinoma. Fine. Okay. Adenocarcinoma pathogenesis, I have two things. Here is where, like Sarkar said, I need both the genetic importance as well as your smoking here, right? Because adenocarcinoma can be seen in non-smokers as well as smokers, right? If it's a smoker, mostly it's a fine variant of smoke which can reach the alveoli. If it's a non-smoker, where also there's a risk of adenocarcinoma. Yes, Daksh, because both of them are due to smoking. Like small cell carcinomas are seen only in smokers. Like 99.9% of them, they'll be smoker. It's smoking related. The mutation is different. That's all. Bhavya, I'll tell you the difference. If they ask in an exam, tell. Otherwise, write them overlapping. Asbestos body is not iron coated. Ferruginous body is iron coated. So if you see a very pale glistening asbestos fiber in microscopy, I call them asbestos body. If it's iron laden, brown color, I call them ferruginous body. But most of the places, these are interchangeably used. Fine. Okay. Non-smoker, especially in the alveoli, which is the terminal part, there's a risk of mutations. There's an increase in risk of mutation because alveoli are very, very flimsy. Because there's more regenerative capacity, there's more risk of mutation, right? What mutations? The same. The KRAS mutation, at least here we'll start with the common ones, EGFR. EGFR is very important. That's the most common mutation seen in adenocarcinoma in Indians. So write that. Definitely KRAS as well. Fine. So now alveoli results in a same. I'll have same dysplasia. Then I have one more stage called an adenocarcinoma in situ. What does adenocarcinoma in situ stand for? In situ means what is not there. There's no invasion, right? Then goes to invasive adenocarcinoma. Okay. Fine. It'll go to invasive adenocarcinoma. Perfect. I have not included the clinical features here for simple reason. Lung cancer will be a long answer. The clinical features will be there in the question. Look at the question, write the clinical features. That's it. Very simple. Don't read everything. Be smart, read simple things and apply in the paper. That's enough. If not given, what do you think will be the clinical features? Hemoptysis, loss of weight, cough, loss of appetite. These are classical clinical features. As well as you have to include paraneoplastic syndrome. Hypercalcemia is common in your squamous cell carcinomas. Cushing syndrome is common in your small cell carcinomas, right? You can add them as well because that also is very classical procedure of lung cancers, right? You have both classical symptoms and paraneoplastic syndrome for it included, fine? Perfect. Let's go to gross. Gross, draw a diagram. It's much easier to draw a diagram and explain. In the same diagram, you can explain almost everything, fine? Just draw a diagram. Put a bronchus. I want you to draw both the lungs. I'll tell you the reason to draw both the lungs. Because there are two tumors which happens in the center. There's one tumor which happens in the periphery. Two tumors happens. One is metastasis, which also happens in the periphery, right? So if possible, use different colors. Okay. So a tumor which is bigger and in the center of the lesion and maybe with a cavity in the center. Okay. Write this. A central lesion, cavity in the center. I want you to fill it up. What do you think of? Next, I have a tumor which is seen mostly in the bronchus. There's a possibility this tumor can damage the bronchus and go outside as well, right? So this is a very classical finding. We call this a collar button lesion. Okay, what tumor is called as collar button lesion, which is also seen in the center. Fill this up. Fine, I'll definitely fill that everything up in the later stage, right? Okay, I have tumors. We'll use a different color, which can be in the periphery. Most of the time kind of well defined in the periphery and they are multiple, right? I have tumors which could be multiple, which could be well defined and they are in the periphery. What could be these tumors? Fill them up. I'll definitely fill them up later. Okay. That's it's simple. Explain it. Take some time, explain, you'll be able to answer it for sure, right? Last but not least, I have an irregular lesion. Okay. Very irregular lesion, can be single, can be multiple, doesn't matter. Irregular periphery lesion, most of the time early diagnosis will be single. What's diagnosis? Central cavitation lesion, it's squamous cell carcinoma. Collar button lesion is generally carcinoid or neuroendocrine tumors, whatever it is, fine. Multiple well-defined periphery, it is your metastasis. Okay, and your irregular peripheral tumor is your adenocarcinoma. Fine. Two advantages of drawing and writing. One, it's neat. If you draw neatly, it'll be neat. If you draw like me, it'll not be neat, right? Second, it'll fill half a page. Third, the examiner knows, you know the spatial orientation of the tumor because this is how you will diagnose in future. You'll have an X-ray finding, you suspect this cancer, you take a biopsy, right? That's why it's very important to draw a representative image. Gross It's simple. Same. If it's a normal epithelial tumor, ulcerative, ulceroproliferative, infiltrative. Lung location, brain location. We know how to diagnose every tumors based on that. Draw diagrams. Need not be different colors. Single color also is more than enough. But draw representative diagrams. It makes much more sense. Fine. Microscopy. Squamous, I'm not going to repeat. We know. Keratin pearls. We definitely know the 4 features of dysplasia. Plus, obviously, I'll have invasion. Right. Someone asked me, right? Daksh, you asked me, right? Sarkar, definitely not important, right? I'll be very honest. I told you in the first class itself, I'll get 5 minutes to correct a paper. If you read 60 pages, honestly, I'll be irritated. If you have one diagram like this, I'll be happy, tick, give a mark and go away. That's much easy, much simpler. If you don't know the answer, write whatever you want. That's how it is. If you don't know, I have to bluff something, right? Write more. If you know, be crisp, fine. Okay, invasion. And put a box like yesterday we saw. Draw a keratin pearl, a world appearance, and very, very irregular nuclei, fine. Thank you, Vaibhav. Next, adenocarcinoma. Adenocarcinoma have 3 things. One is atypical adenomatous hyperplasia, which I'm not mentioning here because it's not possible to identify it. It's an incidental lesion. Next is in situ and invasion. The only finding here is in situ is I'll have the same dysplastic cells which will be lining the alveolar membrane, but it's in situ. Like you guys said, there'll be no invasion. Okay, so try to draw an image. Draw an alveoli, draw an alveoli, draw an alveoli, and then if possible, draw very ugly neoplastic cell, right? So different shaped cells, pleomorphic cells lining the alveoli. This pattern is important. Lipidic pattern. Butterfly sitting on a line, it doesn't look like that. Mine definitely will not look like that, but it's just in the line. It does not breach, and there'll be no desmoplasia in the center. Invasive adenocarcinoma, same. You'll have glands, and here you will have desmoplasia. Desmoplasia is the most important thing here because it's invaded, right? Glands, again, same 4 features of dysplasia, invasion present. The desmoplasia is due to invasion. Okay, same. Draw a gland here. Again, ugly gland. The most important finding here is the desmoplasia, the fibrotic center. Maybe draw a couple of tumor cells here as well, just to mention that there is invasion, right? But if you're able to differentiate this glandular appearance, desmoplasia, non-desmoplasia, that's enough for adenocarcinoma in situ and invasive, right? Diagrams of this sort. If you want to beautify it, great, but it should be representative. That should be more than enough, right? Then neuroendocrine. For every neuroendocrine tumor, one finding which you should not forget is salt and pepper appearance. Every neuroendocrine tumor will have salt and pepper appearance. Wherever throughout the body, it will have salt and pepper, mostly on a higher power image. Then we come to carcinoid, atypical carcinoid or small cell carcinoma. Carcinoid has a pattern, nesting pattern or an organoid pattern. Small cell atypical carcinoma, again no pattern, no particular pattern here. Small cell carcinoma, no pattern, it's just solid sheets of cells. Okay. Plus one more finding, Azzopardi effect. Can anyone recollect what does Azzopardi effect stand for? You guys know Azzopardi effect, right? Bhavya, bronchogenic carcinoma is the other name for lung carcinoma. That's all. It's different. That's it. Bronchogenic carcinoma and lung carcinoma is the same. Is it lagging? I hope it's not. Azzopardi effect is nothing but the DNA surrounding the vessels will have a smudged appearance, or the last one to die, that's Azzopardi effect, right? Perfect. So how do you have to write Azzopardi effect? It's a place where the entire tumor is dead, right? So it's a place where almost the entire tumor is dead. So I'm going to have lots of necrosis in the background. So a pink color background in which you draw an blood vessel here, and surrounding the blood vessel draw bluish DNA. Okay, so surrounding the blood vessel alone, I'm having DNA there. That's your classical Azzopardi effect. You have DNA, perfect, like Soumya said, in the perivascular area. There's a finding of any highly proliferative tumor. Small cell carcinoma is definitely one of the most highly proliferative tumor. you'll have it, right? All of these are cancers. Carcinoid, atypical, and small cell carcinoma, right, is a very low grade malignancy. Small cell carcinoma is one of the most aggressive lung cancer. Okay, not much of pleomorphism, very minimal pleomorphism, no necrosis, just the organoid pattern, that's more than enough, right? Atypical carcinoma, yes, a little bit of moderate pleomorphism, but no esophageal effect. Necrosis plus or minus, it can be seen, cannot be seen. Fine. Okay, I didn't talk about mitosis here. I would say if you are sure about the mitotic count, talk about mitotic count, otherwise ignore mitotic count, because it's a bit difficult for you to remember mitotic count for many tumors when it comes to numbers. If it's possible, less than 2, 2 to 10, more than 10 per 10 high power field, right? If it's required, right? If you're in doubt, don't write. It's better not to write than writing a wrong thing, right? 2 to 10 per 10, HPF stands for high power field. Less than 2 is this, greater than 10 is this. It's, if you remember rightly, write it, otherwise ignore it. Fine. That's the microscopic evidence of neuroendocrine tumors. Again, here also you can draw a diagram. Nesting pattern of tumor cells, right? You have tumor cells inside nest. Some representative diagram to say it is this. If you have scales, draw tables also. It's easy to draw tables and write it. If you don't have scales, just put things. That's more than enough. Fine. Okay. So we know microscopy of small cell, we know microscopy of adeno, we know microscopy of neuroendocrine, right? It does not end without calling IHCs. Can anyone tell me the IHC of squamous cell carcinoma? We did talk about last time as well. If you want, write IHC as a separate thing or include IHC along with the microscopy itself. Ranjith, I have not taken cardiomyopathy for today. If you want, I'll do something. After whatever you guys want, let me know. I'll cover it maybe in some other place. Fine. P40, P63. Cytokeratin is common for everything. If you want, write cytokeratin for everything, right? Adenocarcinoma, TTF1, napsin A, right? Neuroendocrine, I'll take Vinod for sure. Neuroendocrine is your synaptophysin, chromogranin. There are many markers for neuroendocrine. These are few basic things, right? Synaptophysin, chromogranin. We have CD56, 57, bombasin. There are multiple things. At least remember synaptophysin and chromogranin. Again, for every neuroendocrine throughout the body, it's the same marker, right? Perfect. Okay. Treatment, like I said, it could be a primary surgical management to remove, and obviously can have chemotherapy. It can be pre-operative chemotherapy, neoadjuvant, or a post-operative chemotherapy to take care of it. Fine. Sure, Pranjal, I'll try it. Okay, that's about your lung cancer. Lung cancer can definitely come as a lung cancer. Do remember that. Fine. Next, emphysema. Okay, just one page for emphysema. Let's try to include everything. Can anyone tell me tiny definition of emphysema in whatever words possible? Just few classical words or pointers required for the definition of emphysema. Anyone? Emphysema is definitely a COPD where the damage is to the acini or distal to the terminal bronchiole. That's very important, right? When you have an irreversible damage to the wall of the alveoli distal to the terminal bronchiole, we call it an emphysema. Fine. Distension of air space is perfect. That also is a very good thing, right? It's due to destruction of the walls of the air spaces. I want the anatomy. It's distal to the terminal bronchiole. That's very important, right? It's distal to terminal bronchiole, subsequently resulting in dilatation of the alveoli. That's called as emphysema, because every COPD is based on the terminal based on anatomy. That's all. Bronchitis, damage here. Bronchiectasis, damage and dilatation here. Bronchiolitis, damage in the bronchioles. Emphysema, it's a damage in the alveolar sac or the terminal bronchial distal duct or the asthma, right? It's always, COPD is always an anatomical classification. So the terminal bronchiole word is very important. Perfect. Irreversible dilatation of the acini. Acini is nothing but distal terminal bronchi. That's also an emphysema. Fine. So, what about pathogenesis? We know about pathogenesis. What happens in a normal person once you inhale smoke? The smoke is going to activate WBCs. Once the WBC is activated, it will release elastase. Okay, and this elastase will be destroyed by your alpha 1 antitrypsin. The alpha 1 antitrypsin is an antiprotease, right? It's an antiprotease which destroys them. So if a person is going to excessively smoke, or if there is no alpha 1 antitrypsin, in case of an alpha 1 antitrypsin deficiency, so this elastase will be present too much. They have too much of elastase because they're not able to destroy it, or there's too much of smoke. This will definitely destroy the wall, right? It results in the destruction of the alveolar wall, which results in permanent dilatation, resulting in an emphysema. Okay, that's the pathogenesis, right? Perfect. Symptom is simple. Emphysema is a COPD. Every COPD, what's one finding you will have? Chronic cough with expectoration, without expectoration. Chronic cough is by default there, right? Chronic cough. Emphysema people are called as pink puffers. You must have seen that. The pursed lip breathing. They always have the pursed lip breathing. That's a classical finding because you must have seen these patients. COPD patients, I'm sure you must have seen in the medicine ward in the last 1 year, right? Write them. Chronic cough, might have weight loss, might have difficulty in breathing, breathlessness, pursed lip breathing, clinical finding. Same for your chronic bronchitis. Chronic cough with expectoration, again difficulty in breathing, again weight loss and everything, fine. Asthma is also COPD. Okay, I didn't say that, but asthma also will come under that, fine. Okay, so that's about your clinical features, fine. Now the types and the microscopy. It's acini. This is what the diagram we draw. It's an acini. Based on the acini, we have 3 different types. One I have centri-acinar. Centri-acinar emphysema. The central part of the acini will be damaged. It's most common in the upper lobes of lung. Lion, sorry. It's fine. Ignore that. Fine. Since bleps and bullae, I would say it's the size different. A tiny one is a blep, a bigger one is a bullae. When you go to dermatology, you'll read the difference. Like patch plaque, same. Like blep bullae, it's the size which matters. Vasculitis is not there in your CBME, so I don't know whether it will ask you or not. Fine. It's secondary to smoking, and it's the most common subtype as well. Where the central part, as the name says, central part will be dilated. Right. Then we have pan-acinar emphysema. Again, it's secondary to alpha 1 antitrypsin deficiency. I'm just writing AT deficiency. It's a bit more common in lower lobes of lung, and you will also have concomitant liver damage because alpha 1 antitrypsin deficiency will have lung damage as well as liver damage, right? Then we have distal acinar emphysema. Distal acinar emphysema is again secondary to smoking. Distal acinar emphysema is a bit dangerous because quite a few of the terminal part of this neck can cause a bullae, right? Can form a bulla. When it forms a bulla, the symptom is totally different, right? This can rupture and result in a tension pneumothorax. So the outcome is different, right? So microscopy is not required to draw. If you want, draw. It's a very easy way to draw. Divide it to half like we did for glomerulonephritis. This side small round, this side big round, emphysema. That's enough. That's more than enough to explain how emphysema looks like. Gross, if you want, draw that everything here will be round. Here it will be normal and bigger one, right? So if you can write centri-acinar, pan-acinar, it's there in Robbins. If you want, you can draw it, right? Try to make cards like this for 5-mark questions. It's a very simple way to revise. Just few important points. If you have written a proper detailed notes, use a different color for the exam. Okay, this point is important for me. This point is important for me. Fine. Bhavya, I told you answered that also. Your bronchogenic asthma is nothing but the other name for lung cancer. Fine. Right. I'm answering for the second time. Please listen. Okay. Got it. So that's about emphysema. Let's go with long answer question. Just one thing. Tell me what comes to your mind. What will be the answer? What will be a diagnosis? Diagnosis? It's a very simple thing, right? What do you think is the diagnosis? Seasonal allergies, past history, breathing difficulty, chest tightness. It's a classical diagnosis of asthma. Fine. So now I'm just going to give you a random thing. I want you guys to let's try and recreate what you will do in an exam. Fine. So when you know it's an asthma, what all you will write? Let's create a template. You tell me a template. If it's right, I'll say it's right. If it's wrong, let's learn something. Fine. Let's create a template. For asthma, asthma is a disease which everyone here knows. First, I'll write the definition. Can anyone define asthma? If it's possible, in one word, in one sentence, whatever comes to your mind. Asthma, it's a hypersensitive airway inflammation with variable airflow obstruction. That's what asthma is, right? Which might result in cough and wheeze, right? That's a definition of asthma. Whatever you want, you can write it, right? It's definitely a chronic airway inflammation or airway hypersensitivity. Type 1 hypersensitivity will not suit for the definition. That might go into the pathogenesis, right? Okay. It's a chronic airway hypersensitivity, okay, with variable expiratory outflow obstruction. It's obstructive disease. So Lion, you're right. Jaiswal, you're right. Don't worry about it, right? Right? It's an expiratory outflow obstruction, which might result in cough. Wheeze is a very classical finding, including chest tightness, right? That's how it is, right? Now we know the definition, right? So once we know a definition, perfect. So whatever you guys said, we can compile it and put as a simple 1 or 2 line definition. After definition, by default, I'm going to ask about the risk factors. So do you guys know any risk factor for asthma? Anything which comes to your mind? Risk factor for asthma? One of the most important risk factor for asthma is hereditary atopy. If your parents are allergic or asthmatic, there's a very high chance you might have an asthma, right? So hereditary is a very, very important risk factor for asthma. There are few HLA dependent genes. If you remember any HLA dependent genes for hereditary, write them, mutation, write them, right? But there are, in addition to that, there are few triggers for asthma. One of the most important triggers is dust pollution. Do you know any different or special types of asthma? Have you heard about your exercise related asthma? You must have read about exercise related asthma, right? Perfect. So exercise can be a trigger. Pollution dust is definitely the most common trigger. Drugs can be a trigger. We do a drug induced asthmas. Any other triggers? Viruses. Perfect. Viruses can be a trigger. Sometimes a simple respiratory infection can trigger an asthma, right? So these are triggers. Every hypersensitivity will have a hereditary component and will have a trigger. That's what is going to relate the asthma, right? Now pathogenesis. Pathogenesis, like you said, it's a classical pathogenesis of a type 1 hypersensitivity. So type 1 hypersensitivity happens during the first insult or the second insult. We have not revised immunology, but I'm sure you can recollect everything required. Type 1 hypersensitivity is always a secondary insult, right? It's not a primary insult. Primary insult is going to cause sensitization, right? So pathogenesis is simple, classical type 1 hypersensitive reaction, right? Can I the same pollen grain, divide them. See, now I have a pathogenesis given, right? So I need first sensitization. Write one page for what does sensitization mean. Second page for re-exposure and how the patient will have a symptom. That's all, right? The first exposure is sensitization. This is not symptomatic. The person's body enters a pollen grain. That's the most common stimulant. Antigen presenting cells will present the pollen grain to my CD4 T cells. CD4 T cell, which pathway? TH1, TH2 or TH17. There are only 3 different pathways for your CD4. And which pathway will cause allergy? Perfect. Th2 pathway will cause allergy. Th1 always causes granulomatous problem. Th17 causes acute or chronic inflammation, right? These are basics. Never ever forget basics, right? Resulting in Th2 pathway. Th2 pathway, one of the most important thing is it produces my IgE. If you remember the classical interleukins, interleukin 4, 5 and 13, great. If you don't remember, just write Ig, Eg, that's more than enough, right? Interleukin 5 also is important, interleukin 4 also is important, interleukin 13 also is important. Interleukin 5 attracts actually eosinophils. It's eotaxin. Eotaxin is an eosinophilic chemoattractant. This IgE goes and sits on the top of a person, which is mast cells. So IgE binds here. That's the first step, sensitization. In sensitization, there's no symptom at all, right? Then re-exposure. Second time exposure, what happens? Will I have more antigen? Yes. Re-exposure, again with the same antigen pollen brain. Already have a mast cell which has got antibody on the tops of it. The pollen comes and sits on them, right? So now I have an antigen antibody reaction. So this causes multiple things. Can I say what will be the immediate effect? Will it produce multiple interleukins and attracts WBC, or it will have an immediate phase where you will have only your degranulation, right? The primary thing is, or the immediate phase will be mast cell degranulation, right? So we have an immediate phase, we have a late phase response. Immediate phase happens at the earliest, as soon as you have the minutes of exposure, maybe to few hours. Late phase starts after 2 to 3 hours. It starts a little bit later, right? Immediate phase will last for minutes. Late phase happens after a few hours. The predominant reason for late phase is interleukins and the chemotactic factors and new WBCs, which comes into the play. Immediate phase, the predominant one is the preformed antibodies, the preformed mediators, and the prostaglandins and the leukotrienes and everything. Okay. C4, D4, and E4. I'm just writing leukotrienes, fine. Now let's go back to your inflammation chapter. I'm sure you can write at least an essay on inflammatory mediators, right? You can write on histamine, serotonin, what they do, vasodilatation, increase vascular permeability. I'm 100% sure you know what does leukotriene C4, D4, E4 does, right? What do they do? They causes your bronchoconstriction, again increase in permeability, fine. See, obstructive lung disease has asthma, COPD and others. When I call it COPD, emphysema and chronic bronchitis are very chronic. Asthma can also become chronic, right? Because it's an intermittent acute exposure. That might be the reason in line they said it's not a COPD. It's an obstructive lung disease. It's an obstructive lung disease. Bronchiolitis is also an obstructive lung disease, but primarily not a chronic obstructive lung disease, because chronicity is always secondary to your smoking exposure. That's where my stimulus is going to be very, very recurrent, and that's how it is, fine. Obstructive lung disease, I have bronchiolitis, I have asthma, I have your bronchiectasis, I have your emphysema, and I have your bronchitis, right? All of them. If you want only COPD, I go into your bronchitis and your emphysema, fine. Pamish and also Jaiswal. Okay. Now we can easily write what is based on that, fine. Then you know the symptom, you can easily write the symptom. We know the pathogenesis. Then diagnosis. Lab diagnosis is actually nothing, it's useless. But if you want, right, use a sputum examination. You know the findings. You have your Charcot-Leyden crystals, which makes them happy, your Kirschmann spirals, okay, and your Crayola bodies. You can expand a lot here. And obviously, you know the treatment of asthma. Pulmonary function test, if required. Actually, lab requires only a stethoscope. You know it's a wheezing, we go and treat. That's all. These are just to make the pathologist happy. They want to see something in microscope, right? No one requires that, but just to write them. Treatment, you know very well, an entire chapter is there on pharmacology on treatment of asthma. If you have time, add a thing on treatment as well, right? See, it's a thing of a respiratory system question. Definition you knew not from books, mostly from experience or your medicine postings. This again you know You knew it from your personal experience most of the time, that's all. This you know from general pathology, sixth chapter. This you knew from general pathology, second chapter. This is what we must have read in your respiratory system. So a question need not come from the same place in the book. You have to recreate, you have to structure the question. The most important thing for that is a very calm and a patient mind. If you are little bit apprehensive or scared about an exam, exam wins you. If you're not apprehensive, you're like, it's just an exam, you win over the exam. The attitude is very, very important, because this is an example of a long answer. You don't know where you wrote from, but you know the answer. You know how to structure it. This is the same way, for every long answer. We have read the entire year systematically. Any question I ask, it's inflammatory or autoimmune or your genetic or your necrotic chapter, right? From there, you take the points, add it, create a template, write it, right? It's not difficult, it's simple. Let's meet you after Jan. You'll say definitely second is easy, third year is difficult. It'll change every time you have a problem, every time you have a solution out of it, right? That's about asthma. Okay, it's fine line. Don't see, there are only two things. Remember this always. If you are worried about an exam, you cannot write the exam. Anyway, you fail the exam, right? Not fail or don't do well in the exam. Then why to worry? That's not doing any change for me. Carefree attitude. Right? Don't worry. Go and write. You have studied well, you'll definitely do well. Okay, banana shake. Why pap smear happens is, why pap smear is helpful is, for a cervical cytology, I need to know the keratinization. Right, so when you look at the microscopy of a squamous epithelium, if I do an H&E, right, if I do an H&E, everything looks pink in color. Be it a stratum spinosum, stratum granulosum, stratum corneum. But when you do a pap smear, stratum corneum looks orange, stratum spinosum granulosum looks different color. That's why, since I need to know what stage of cell it is, we go for the your pap smear over H&E. But H&E is also done. Fine. Okay. That's what will happen. Nothing will happen. Don't be anxious. It's not useful anyway. Right? So ignore it. Okay. The Farre will be there. I hope you guys are reading the 8 core modules as well. It's important. 1 5 mark comes from, unfortunately, 8 core modules. They should give 8 core modules for the rest of the world, not for us. Unfortunately, they're giving it for us, right? Since now next class of Farre, I don't know. Just give me a second. I'll see it. My next class on Farre is on 18th of November, GIT. Fine. Daksh, let's finish this. We'll come back with gross and microscopy also. Trying to develop something for microscopy, hopefully. Thank you, Santosh. Yes, Samantha, it's available in the mod app. Just go and have a look at that. Fine. Bye-bye.